Shaq, can you see us? Yeah, I'm able to hear you. Can you see me and hear me? Okay, so we have a patient of around 11 years now. PowerPoint.
Of a mama, which was detected during his school health program. Also, he is complaining of poor weight gain and NVHA class 2 breathlessness. The parents were told that the baby has some murmur in early infancy, but they didn't follow up. On examination, he is severely malnourished, weighing 18 kg, expected against an expected weight of 30 kg, with a respiratory rate of 28 per minute. Pulse rate is 90 per minute. His forelimb BP and saturation is showing wide pulse pressure. Cardiomegaly, as evidenced by the apex beat in left fifth intercostal space, 1 centimeter lateral to the midclavicular line. He is having a continuous murmur of grade 3/6 at left upper sternal border. X-ray is showing situs soltus, levocardia, CTR of 65%, MPA is dilated, pulmonary plethora. ECG is showing sinus rhythm with a ventricular rate of 75 per minute, QRS axis of 75 degree, left ventricular hypertrophy, LV volume overload pattern. Clinical diagnosis, it's a congenital acyanotic heart disease, increased pulmonary blood flow, moderate size PDA. So we proceeded with an echo. This is 4-chamber view showing dilated LA-LV. In this modified parasternal short axis view, we are seeing a color flow pattern which is not typical of the PDA. It is somewhat proximal. So that raised a doubt of aortopulmonary window. On measuring, it was found to be 7 mm into 7 mm.
Ask them to give another sedation.
This is that aortopulmonary window without color flow. And this aortopulmonary window was found to be around 14 mm away from the pulmonary valve.
You can go to
so diagnosis, echo-wise is 7 into 7 mm, intermediate type AP window with a peak systolic gradient of 60 mm mercury, 14 mm distal from aortic and pulmonary annulus. There was also a pan-diastolic flow reversal noted in ascending aorta and arch, dilated LA-LV, trivial TR, good biventricular function. Sir, regarding oximetry.
So Shaq, we will show some live echo now. Echo big. So this is. So Avinash.
The parasternal short axis showing the color flow across the defect between the aorta and the PA. The frozen frame showing the defect measures around 8.3 millimeters. The long axis of the aorta showing the defect. The frozen frame showing the distance from the aortic annulus at least 2 centimeters. The short axis showing the pulmonary regurgitation and the distance from the pulmonary valve in the frozen frame at least 15 millimeters. The dilated LV measuring around 62 millimeters.
So hemodynamics live. Yeah, so basically we have done the QPQS. The QPQS is more than 4:1. The pulmonary artery saturations were 92 millimeters of mercury in the distal RPA and distal LPA, giving a shunt of more than 4:1. We are showing the live pulmonary artery pressure is around 84 against an aorta of 139. So right now what we are doing is we are going to cross the AP window live. So I'm going on fluoroscopy. We have got a internal mammary catheter at the pulmonary artery. Yes. So okay. Sure. So we are in the AP window. Fluorostor. So Shaq, you are back with me. So okay, so we are going to cross the AP window now. So that is my catheter going into the ascending aorta, but it is not remaining stable. So now I will try to manipulate. So now we have got the catheter, we have got the guide wire going into the subclavian artery. Are you seeing us live? Okay, show the subclavian artery. Yeah, go inside. We'll enter the subclavian. Go inside, catheter inside.
Not advancing, it is getting kinked.
Yeah, no, that is an internal mammary catheter. I wanted a sharper curve on the, sorry, stiff wire up there. I am planning to enter into the subclavian now. So once I am into the subclavian, yeah, since it was a 8 millimeter AP window, you also saw that the pulmonary artery pressures were pretty high. So we are using a 1210 PDA device. Show the, with the QP by QS of 4:1, we feel that the PDA device with only one disc on the aortic end and no disc on the pulmonary end will still not stand a chance of embolization, because we anticipate the pulmonary artery pressures to come down substantially. So right now I am taking out, show the heart. Yes. Shaq, with the pulmonary vascular resistance being quite low, even though the PA pressure is high, and a large shunt, with the device, the aortic pressure is going to press the device against the pulmonary artery and give us reasonable stability. The proximity, yeah. We thought that since the defect was 8 millimeter, we are going to choose a 1210 PDA device. It's a LifeTech 1210 PDA device. Any your suggestions, Shaq? The 1210's pulmonary end is 18. Aortic retention skirt is 18. Yeah. So right now I am going to come with a pressure guidance. See, I have connected the side arm of my Mullin sheath into the subclavian artery. It is right now getting somewhere, it's about 160. So we are pushing in a 1210 LifeTech PDA, which is going across. So this is opened. Can you? I have now aortic pressure. So I will withdraw on my pressure guidance. Can you? So right now I am seeing the separation of the pressures. So at this, so now I'll find out whether I have trapped my pigtail. And so I will take out the pigtail with the wire and reintroduce. Actually, my aortic catheter has gone into the PA. You saw that? Just fluorostore that. Fluorostore that. Okay, I'll show you that fluoro. Show that. See, at this particular point, my pigtail has got sucked into the AP window from the ascending aorta. So now I have taken it out. So this is the ascending aorta. Now we are going to go live with an angiogram, connect angiogram. Actually, the moment I release, it will get aligned properly. You are ready? Shoot. Shoot. Okay. Get ready for an angiogram. Yeah, I agree, Dr. Allison. Muscular VSD is another choice. However, the cost between duct occluder and the muscular VSD in our country is like 2:1. Okay, so right now we can see that the aortic disc is sort of tilted towards me. So I will give a gentle push, and at this particular point I will try to go and deploy. This is a session named by TIN as complications A to Z. So let us see what's happening. I told TIN that it is not a good idea to name a conference as complications, but still he persisted. Sorry for poking the cable on the right ventricular wall transiently. Okay, another angiogram. Get ready, Mohammed. Last angiogram. Then I will give the hemodynamics. You are ready? The right ventricular pressure is about 55 millimeters of mercury now. Yeah, and the aorta might have gone up, I think. Yeah, just we are waiting for the injector to be loaded. In the meantime, I'll just show you once the aortic pressure live. Yeah. 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 So your choice will be a muscular VSD device? Yeah. Yeah. So then you mean it is pulled more into the PA? Okay. I will make a magnified view now. You are ready for the angio? Yeah. Zoom it. Zoom it out. Zoom. Yeah. Ready? Ready? The waist could have been a little bit more towards the aorta, no? Yeah. Yeah. Echo. Echo live. Yeah. The aortic retention skirt was deployed in the ascending aorta. You said the whole device itself to be color. Echo live. Echo live. So this is the echocardiogram now. In echocardiogram, actually the device looks good. So RCA. Yeah, just one PA pressure I will get you. Yeah, yeah, yeah.